With anatomy out of the way, let's move on to renal physiology. This is where the bulk of the material will be for renal. Since the kidneys are the primary regulators of body fluid volume, let's start with a discussion of fluid compartments. You probably remember that the body's total water is split into several different compartments. Before we get into the differences between them, let's just walk through a sample problem. Ready? So how is the body water of a 70-kilogram man divided? Let's go through it together. If he weighs 70 kilograms, then 60% of that, so we can multiply that by 60%, will be water, or about 42 liters. Then 2/3 of that is intracellular, so if we take that 42 liters, multiply it by 2/3, we get 28 liters. The remaining 1/3 will be about 14 liters, and that's extracellular. Of that, about 1/4 or 3.5 liters is in the plasma, and the remaining 10.5 is in the interstitial space. Now that we have our example calculation, let's talk about the differences between these compartments. The extracellular fluid, or ECF, has a very different composition than the intracellular fluid, or ICF. The major cation in the ICF is potassium, while in the ECF it is mainly sodium. As you remember, this same concept is taken advantage of by the nervous system to facilitate action potentials. Sodium, which is the major extracellular cation, enters the cell, while potassium, the major intracellular cation, exits the cell. The ECF and ICF also have different anions. In the ICF, it is mostly protein and organic phosphates, while in the ECF, it is chloride and bicarbonate. Importantly, however, the osmolarity of both compartments is about the same at 290 milliosmoles, which means there's no net movement of water in and out of the cells at rest. One important thing to remember is that the calculations we just did only give you estimates of fluid volume. In order to measure plasma volume directly, you can infuse radiolabeled albumin, since albumin will remain only in the plasma. Similarly, in order to measure all the ECF directly, you can infuse inulin, since it will remain only in the ECF without going into cells. In real medical practice, no one would ever do these things. They are slow and expensive, and the simple calculations we did are good enough for most purposes. But on the exam, you might need to know how to use these tests. Let's see how that would work with a sample question. Ready? You infuse 1 gram of radiolabeled albumin into a healthy 70-kilogram volunteer. After equilibrium has been reached, the plasma concentration of radiolabeled albumin is 25 milligrams per deciliter. What is your volunteer's plasma volume? In order to answer this question, we just need some simple math, which I still hate. We infused 1 gram, or 1,000 milligrams, of radiolabeled albumin. If the concentration ends up being 25 milligrams per deciliter, and we started with 1,000 milligrams per deciliter, then there must be 1,000 divided by 25, or 40 deciliters of plasma. Let me work that out for you. So we started off with 1,000 milligrams, and we want to solve for deciliters. So we divide by milligrams so that we end up with deciliters. That gives us 40 deciliters, which equals 4 liters. That's roughly equal to the 3.5 that we calculated in the beginning of this lecture. Thus, for your test, you can see it is important to remember that various substances can serve as surrogates for different food compartments. For example, inulin will often be used on the test as a reference to the ECF, and this is worth remembering. You will see this concept again when we discuss glomerular filtration. Now let's move on to the actual functions of the kidney, starting with filtration. The glomerulus is a very delicate structure that acts as a filter for plasma. The way that the glomerulus achieves filtration is a variation on a common theme in human anatomy. If you remember the blood-brain barrier, it is composed of 3 layers: an endothelial layer, a basement membrane, and astrocytic end processes, This is a very poorly drawn diagram, but I'm using it to illustrate a point. The glomerulus uses the same exact concept. It has an endothelial layer, a basement membrane, charge barrier, but instead of astrocytes, it uses podocyte foot process to form the third barrier. The kidney makes a tight meshwork to prevent things from leaking out of the vasculature. This is especially important to keep protein, which tends to be large and negatively charged, inside the blood. If this barrier is lost for some reason, the kidney will leak protein, leading to decreased oncotic pressure and edema, as is the case in nephrotic syndrome. Normally, only small solutes are freely filtered through the glomerulus. Now, let's move on to some equations that are important for renal physiology. The math involved isn't too complicated, but you should still be comfortable doing these calculations, so we'll go through some examples as we move forward. Let's start with renal clearance, a concept that is especially important for pharmacology. Clearance basically describes how much plasma is cleared of a certain substance X over time. One important thing to remember about clearance is how it compares to GFR, which we'll talk about in a minute. It's also important to remember how that relates to the net absorption or secretion of a particular substance. One thing that is important to remember is that when you are discussing a substance that is actively secreted from the kidney, increases in plasma concentration initially lead to increases in clearance. However, as the plasma concentration continues to rise, the secretory mechanism becomes saturated, and increasing plasma concentration leads to decreases in clearance. This makes sense when you look at the equation. This is a concept that can get some students into trouble on test day. Before doing a sample problem, let's talk about GFR, or glomerular filtration rate. Conceptually, this is how fast fluid is filtered through the kidney, but practically, GFR is used as a proxy to measure kidney function. It also represents the balance between stalling forces in the glomerular capillaries, hydrostatic pressure trying to push fluid out, and oncotic pressure trying to keep fluid in. You should also remember that inulin clearance is the perfect method for measuring GFR, but almost everyone uses creatinine clearance because it's easier to measure clinically. Let's do an example calculation. Calculate GFR using the following values for inulin: urine concentration of 100 mg per deciliter, a urine flow rate of 50 cc an hour, and a plasma concentration of 60 mg per deciliter. Using the formula where GFR equals inulin clearance, GFR equals the urine concentration times the urine flow rate divided by the plasma concentration. This is equal to 83.3 milliliters an hour. This again is roughly equal to 1.4 milliliters per minute. Now, this same patient has the following concentrations for sodium: urine sodium of 70 milliequivalents, a urine flow rate of 50 cc an hour, and a plasma sodium of 140 milliequivalents. Does the patient have net sodium reabsorption or secretion? Now, the clearance of sodium would be equal to 25 cc an hour, or 0.42 milliliters per minute. Since this is less than the GFR, which was 1.4 milliliters per minute, there is net reabsorption of sodium. Now let's move on to renal plasma flow. Conceptually, this refers to the amount of plasma flowing through the kidneys over time, but it can't be measured directly. Instead, we use effective renal plasma flow to estimate it, even though it's an underestimate by about 10%. Once we have renal plasma flow, we can use that to calculate the full renal blood flow using the formula that adjusts for hematocrit. So here's a question related to renal blood flow that may be useful for you to remember. How much of the resting cardiac output do the kidneys receive? The kidneys receive about 25% of the resting cardiac output per minute. This is typically anywhere between 1.2 to 1.3 liters. This next fact defines filtration fraction. which is the fraction of plasma going through the kidney that gets filtered and is calculated by dividing GFR by RPF, or renal plasma flow. It's normally about 20%, but it can be altered either with natural hormones or with drugs. For example, angiotensin II preferentially constricts the efferent arteriole, which leads to a decrease in renal plasma flow, but also leads to an increase in GFR by increasing the hydrostatic pressure gradient, so the filtration fraction increases to more than 20%. This and other changes in arterial dynamics are laid out in the following table. Okay, to understand this table, you need to understand how RPF and GFR will individually respond to each of these effects. Since RPF is just a measure of blood flow, anything causing arteriolar constriction will lead to a decrease in RPF. On the other hand, to understand the changes in GFR, it's important to think about the stalling forces that we talked about: hydrostatic pressure and oncotic pressure. Efferent arteriolar constriction, like we talked about with angiotensin II, causes an increased hydrostatic pressure gradient at the level of the glomerulus, which leads to an increase in GFR. On the other hand, afferent arteriolar constriction leads to a decrease in the same gradient, causing GFR to go down. The same hydrostatic pressure gradient is also decreased by constriction of the ureter, which decreases GFR. This is because ureteral constriction increases the hydrostatic pressure of Bowman's space. The changes with plasma protein relate to the oncotic pressure gradients. Let's think about this in the context of some sample questions. Ready? In a patient suffering from protein malnutrition, would you expect GFR to be higher or lower than normal? If you said higher than normal, you're right. Someone suffering from protein malnutrition would have low serum albumin since she would not be able to make enough protein. With that lower plasma protein concentration, the oncotic pressure keeping fluid in her plasma would be less, so her GFR would be higher. Now on to question 2. How will the filtration fraction of a patient in the earlier stages of shock compare to a normal filtration fraction? Now this is a tough one. When people are in shock, they aren't getting enough blood to their vital organs. In the kidneys, this means that RPF will be low. The body responds by selectively vasodilating the afferent arteriole while vasoconstricting the efferent arteriole. This has the effect of increasing the hydrostatic pressure in the glomerulus, which in turn raises the GFR. Since RPF is decreased, but GFR is increased, the filtration fraction will be higher than normal in the patient with shock. Great! Now let's finish up these calculation-heavy topics with a brief mention of reabsorption and secretion rates. Using the equations listed here, you can calculate how much of a substance gets filtered through the kidney and how much gets excreted. If there is more being excreted than filtered, then somewhere along the nephron there must have been net secretion. On the other hand, if more of it is being filtered than excreted, somewhere along the nephron there must have been net reabsorption. With those concepts under our belt, let's move on to 2 specific substances where it's very important to know how the kidneys are handling them. The first is glucose. Normally, glucose is freely filtered through the glomerulus, but it is completely reabsorbed in the proximal tubule through co-transport with sodium. That makes sense since glucose is very important to your body, and peeing all of it out wouldn't be a good way to live, or stay alive for that matter. However, If the plasma concentration of glucose gets high enough, the glucose cotransporter reaches its maximum rate and can no longer reabsorb all of the glucose, and some of it remains in the urine. The problem gets worse the higher the value of glucose. This is a key problem with what disease discussed during the endocrinology section. Of course, diabetes mellitus. The very elevated plasma levels of glucose eventually lead to increased levels of glucose in the urine, which causes an increased amount of fluid in the urine and increased urination. This is one of the hallmarks of diabetes. The second important substance to understand is amino acids. Normally, these are small enough to be freely filtered through the glomerulus, but then they are completely reabsorbed by cotransport with sodium. There really shouldn't ever be amino acids detected in the urine, and if there are, it's a sign that there might be some genetic deficiency in amino acid reabsorption. If you can remember from biochemistry, Hartnupp's disease is the result of a deficiency in a neutral amino acid transporter. This leads to an inability to reabsorb which amino acid? Tryptophan. And since tryptophan is a precursor for niacin, this results in pellagra.